Nice to see you all. Thanks for coming to London. You got here just in time before the weather hits. It's supposed to get rain later on, but it's warm. It's spring, right? In a week's time, we're going to have an explosion of green everywhere on the trees. It's an exciting time. Really happy that you were able to come to London, Ontario. And I'm going to run you through everything you need to know about diabetes in the next, and I'll try and make up time, 45 minutes or so. Can the clinicians in the room put up your hand, just so I know kind of an idea how many people are?
You mean like nurses?
Yeah, anybody, who sees a patient or has ever seen a patient or... Okay, great, thanks. So this is really oriented towards you. I've tried to keep it as basic as I can. I'm happy to take questions as I go along. And this is, honesty is not intended to be a complete overview and detailed lecture on diabetes, but it's to give you a sense of diabetes. I'm going to show you stuff from the new clinical practice guidelines that were published a few weeks ago, available online. So I'll bring you up to date with the latest from the guidelines from 2018 from Diabetes Canada. It used to be called Canadian Diabetes Association. I still call it CDA, but millions of dollars later, it's called Diabetes Canada. But I'll be happy to take any questions as I go along. And I've oriented the presentation to focus in particular on First Nations. Some of you may know that I've been involved in working with First Nations communities since 1990. I guess that kind of dates me. Where I lived up in Northern Ontario in Sioux Lookout for almost 6 years, working with 30 fly-in reserves in what's called the Sioux Lookout Zone. And that's where actually I got into getting involved in diabetes and diabetes research, in particular with, I'm very proud to say, my partnership and collaboration with Sandy Lake First Nations, which really, the leadership there really helped put diabetes on the map, if you would, for Indigenous Canadians and globally, with some very important groundbreaking research that showed how much diabetes there was, why was diabetes happening, and tested out various strategies and interventions. So for me, coming to talk to you today is a lifetime commitment and opportunity to share all that we've learned, and really excited to be talking at this workshop, because the activities that took place during the Forge Ahead pilot really resonated with the communities that participated. And I have to say, in the 2 decades plus that I've been working with First Nations communities here in Canada, this is the thing that really seemed to work. And that's not me speaking, it's the community saying. So you're participating in what has been demonstrated in the Forge Ahead pilot to be a successful strategy on how to change things, how to improve healthcare programs, healthcare delivery, better operations at the community level. So you're going to be doing all the heavy lifting. Sorry, but this is work, and it's going to be work that you're going to do back in your communities, but it's gratifying work. It's not just work for the sake of work. You're going to see change, and that's what the communities have told us today. That's why we are so excited to partner with you to demonstrate that we can ramp this up. And our goal ultimately would be to have this in 618 First Nations communities across the country, because I think it works. That's what the communities have told us. This works. And your PDSAs, you may not know what they are now. Honestly, I swear to you, by the end of this, you're going to be dreaming in PDSAs. When you say dreaming in Technicolor, and the communities tell us that they PDSA the hell out of everything. It is a part of their lexicon now, and they do it not just in health, they do it for planning everything, lunches and community get-togethers, etc. So it's a strategy. It's an operational strategy. So I want to acknowledge the Western team, my team here here in London who are fantastic and have pulled together, done a lot of work behind the scenes to get this workshop together, but to write the grants, to carry out the activities, to facilitate easy adaptation by groups such as yourselves, in particular Mariam and Megan, who are leading this endeavor. And also want to thank all of you. You're going to, as I mentioned, you're going to be the ones doing the work. And so in advance, I'm thanking you for your commitment. And I'm hoping, really hoping that you're going to have the same kind of satisfaction in spite of the work that's ahead of you that the other communities have demonstrated and are so excited about. And so our plan ultimately is to build a network of communities across the country, that the communities are going to be the leaders in this area to help move, you know, the pendulum finally to try and change the direction of this terrible epidemic called diabetes, which I'm going to launch into now. I work with anybody who's interested in diabetes, so all the pharma companies, Health Canada, the Juvenile Diabetes Research Foundation, CIHR, Lawson Foundation, etc., all with the same goal to try and improve the care of individuals living with diabetes and their families and communities. So the objectives here are pretty straightforward. It's to kind of help you get a sense of what diabetes care is all about, and to empower you a little bit with a little more knowledge around helping you and your colleagues in your communities do clinical decision making. And as I mentioned, we're really lucky we're doing this in May and not in March because we have the new clinical practice guidelines that are embedded in this presentation. This is a quote from way back when I was working up with Sandy Lake, etc., and I still think it's the best quote I've ever come across when it comes to diabetes and indigenous populations. And diabetes is the inability to process the sweetness of life, and it certainly, I think, was reflected with the opening prayer that we had from our elder this morning. Okay, so why do we care about diabetes? We could be talking about arthritis. We could be talking about respiratory diseases such as asthma, lots of different things. But we know that diabetes, there's a preponderance, there's a high amount of diabetes in First Nations populations, much higher than the general population, 3 to 5 times greater than what we see in the general population in Canada. So there is a genetic predisposition, if you would, that's combined with the environment that First Nations people live in here in Canada now, and other populations, other indigenous populations around the world, same kind of patterns, where there's a higher risk for developing diabetes in general, but a higher risk for developing diabetes at a younger age, at a much younger age. In particular, a higher risk for developing diabetes in women compared to men, which is the complete opposite of the rest of the world. Men always have higher rates of diabetes, except in indigenous populations where women have higher rates. There's something very unique about the susceptibility, if you would, to diabetes here in Canada and First Nations in particular. There's also higher rates of complications, and I'm going to go into these in a little bit of detail, but particularly kidney disease, of which there is already higher rates of kidney disease in our First Nations here in Canada. But you throw diabetes into the mix, and it's a terrible combination. So you go to any dialysis program across the country, 4 out of 10 people in any dialysis program are going to be of Indigenous background. Just to give you a sense, 18 times higher rates of end-stage kidney disease in First Nations compared to the general population. So, the guidelines have rewritten the chapter around diabetes and Indigenous populations. Mariam was one of the authors of these guidelines. And one of the framings of the guidelines, instead of just being focused on clinical evidence around diabetes in First Nations, they've really embedded the concept reflected by the Truth and Reconciliation Commission, for example, around the legacy of colonization and the implication that has in chronic diseases such as diabetes, as well as outcomes. recognizing the social determinants of health and how big an impact that is having in putting people on and off reserve at risk for diabetes, and accessing health care, and trying to create a more positive relationship between clinicians and Indigenous peoples to improve outcomes. Mona.
Thank you for that. Thank you, thank you, thank you. I've been working in diabetes almost as long as you have. I'm sure you're happy to see that as well.
Yeah, no. It's very unusual in a clinical document like clinical practice guidelines to have that reflection. And I think, and kudos to Diabetes Canada for encouraging it. And Mariam was one of the proponents of ensuring that was in there. But I think, the TRC has kind of set a new bar as to everything moving forward, everything involving Indigenous populations. I think we have a pretty, action is a different thing, but I think we have a pretty positive government now, federal government, that really wants to see a change in the relationship. I mean, Trudeau was in the news yesterday with, he was at AFN. I think he survived, just barely. I don't know what the vote was.
This morning.
Yeah. So, but at least the intent is there, and that's a completely different attitude. I've been working with the federal government for decades, and at least it feels like there's the intent to try and move things forward, but all based on this effort to try and create a positive relationship and decolonialize, if you would, the attitude and approach that is embedded in the way policies have been set up, etc. The goal, of course, and this is where you come into it in particular, is building therapeutic relationships. Diabetes is a lifelong disease, so it's not a surprise that there should be continuous self-reflection. I'll mention lifestyle as one of the modalities, the frameworks for which we approach treatment of diabetes. And lifestyle works always. We think that, when you're first diagnosed, that's when you get your lifestyle counseling, diet and exercise. But in fact, it is always a clinical modality that we should include at all stages of diabetes. And it takes some people longer to kind of get there or to revisit it. And often when people are diagnosed with a complication related to diabetes, they go, okay, now I want to kind of take that on. So it's a continuous lifelong effort. The focus always is on modifiable risk factors. What are these? These are things like weight and smoking and exercise and diet, etc. And the sooner you get started on that, the better. We have in provinces like Manitoba, the diagnosis of diabetes is higher for type 2 diabetes and type 1 diabetes in children now, and that's being driven by Indigenous populations in Manitoba. So, a lot of the work that, the groundbreaking work that happened in Sandy Lake was focusing on school-based programs and lunch programs and after-school programs targeting at-risk children, so modifiable risk factors are something that you start to do, and I'm going to talk about targeting modifiable risk factors in utero, in pregnancy, because, and I'll talk about that towards the end of I'll come back to the end of my presentation. Better access to screening, interpretation, follow-up, again focusing on women and girls, particularly in childbearing ages who are Indigenous background, because of the exceedingly high risk that they have for developing diabetes in pregnancy at a younger age, and the risk that they put their developing fetus, newborn, at risk for developing diabetes while they're carrying that baby. While it's growing. And hence a big focus on gestational diabetes and postpartum follow-up, which we've done research on, and it's inadequate. It needs to be improved. And it might be something you want to consider when you go back and do your own PDSAs in your communities, if this is one of the areas you want to focus on. Okay, so how do we screen and diagnose diabetes? Very busy slide. Let me simplify it for you that the easiest screening test for diabetes is hemoglobin A1C, the test that we do every 3 months in people with diabetes. The diagnostic criteria have not changed, so those of you who want to know what is a normal A1C, it's less than 5.5%. So if you go and have a blood test and it's less than 5.5%, that's what a normal A1C in someone who doesn't have diabetes or prediabetes is like. If you have an A1C between 5 and 6, that's an indication that maybe it's early pre-diabetes, that you might want to screen a little more frequently rather than every 3 years, which is the recommendation after the age of 40, but that's different in indigenous groups. If you have an A1C between 6 and 6.4%, that's pre-diabetes, and the diagnosis of diabetes is based on an A1C of 6.5% or higher. Now you notice that you can also do a fasting plasma glucose, FPG. The advantage of an A1C is you don't have to be fasting, right? And it's hard to get people to come in when they're fasting. So an A1C you can do any time of day and you can repeat it. Remember that as with the previous guidelines, you need a confirmation of a second test. It could be a combination of a fasting plasma glucose greater than 7 and an A1C greater than 6.5. Or it could be 2 A1Cs that you can do this week and maybe another one in a month's time or something like that. I like the A1C test because it's easy, you don't have to be fasting, and it really represents more of the overall blood sugar rather than a spot blood glucose test that morning. So it represents the last 3 months. So I think it's a more representative test.
So the in-office A1C machines are, how do you feel about that?
They're okay. They're for the most part, they're hard to, not everybody has access to them because most plans, they're expensive, don't cover it, but an A1C is an A1C. And those have been validated, that they're accurate. We don't do 75-gram oral glucose tolerance tests, glucolas anymore for screening for diabetes, except sometimes in pregnancy.
So, excuse me,
Yep.
That's new to the 2018 guidelines then?
Yeah, these are the two, go back one slide. Everything I'm showing you is based on what was just published last month. And they're available online. I'll show you the website at the end of the presentation. But these are the new guidelines, which are basically reinforcing. There's nothing new really in terms of screening here. Okay. So I'm going to use a case example to kind of walk you through for the clinicians in the room, and we'll present Maria, who's 42 years old. She's a mother of 3. She works as an admin assistant. She's come in for a routine checkup, and the question is, would you screen her for diabetes? I think everybody, that's kind of one of these rhetorical questions. Yes, otherwise I wouldn't have put the case in here for us to talk about someone who's developing diabetes. She has her past history. She's had gestational diabetes. That means that her risk for developing diabetes after being diagnosed with gestational diabetes is 50% within 5 years. Okay? She's also got a strong family history of diabetes. She's sedentary. She's overweight with a BMI of 31. She also smokes 1 pack a day, so her cardiovascular risk is quite high. And give me a reason why you would not screen this woman for diabetes. Go ahead. Okay, does she have diabetes? Her fasting glucose test is 8.6. Her A1C is 8.1%. She's got 2 positive tests done at the same time. She's got diabetes. You don't have to do anything else. You can tell her when she comes back and say, you got diabetes. So I'm answering the question. Yeah, skip the question. Okay. Now, diabetes is a tough disease. Why is it a tough disease? Because it's a progressive disease. Why do we keep telling people you need more medication over time? It's because you get progressive decline of the body's ability to make insulin. So the longer people have diabetes, the worse their control becomes because they're just not making enough insulin to kind of control their blood sugar. So we add more pills, and penultimately we tell people you need insulin. And it's not supposed to be a death threat. It's not supposed to be, you're telling the patient they've been bad. is just because over time the body doesn't make enough insulin. If you had a patient with type 1 diabetes who needs insulin to live, to survive, you wouldn't say you're being bad, I'm going to put you on insulin. You need insulin because you need insulin. Just like you need thyroid hormone. Insulin is a hormone. And we see that, this is a study we did about 10, 12 years ago, where we see progressive decline in control in people with diabetes that reflects the progressive decline in the body's ability to make insulin. So you have to be mindful that this is a progressive disease. So you have someone who's sitting in front of you who was diagnosed this past year versus someone who was diagnosed 10 years ago. You can anticipate the person who's had the longer diagnosis is going to be on more medications. And penultimately is going to need insulin to help maintain the control, because the pills just aren't going to cut it anymore because there's just not enough insulin on board. So that's what this shows, that after 10 to 14 years, only a third of Canadians with type 2 diabetes are still at the recommended guideline targets because we haven't kept up with therapy. And why do we treat diabetes? What do we care? Why are we so obsessed with getting patients to target? Because there's solid evidence. It's now 20 years old and being reinforced over and over and over that if you control blood sugars, you prevent complications. In particular, you prevent microvascular disease complications. These are the small vessel diseases, the little tiny vessels that feed the kidney, that feed the eye, that feed the nerves, and penultimately feed the heart and brain as well. And we know that for every 1% reduction in A1C, you see these kind of benefits, 21%, 14%, 37%, 43% reduction in the progression and development of complications. So even if you have a patient with an A1C of 11%, terrible control sitting in front of you, if you get them down to 10%, still terrible control, you've effectively reduced their risk for developing these complications by this amount. So every little bit counts, and it always counts. So proper management is important. And the guidelines like to come up with this A, B, C, D, E, S, S, S. So the new guidelines have added an extra S or two. So A1C target, as I'll come back to these, is A1C for most people is less than equal to 7%. Blood pressure, the blood pressure targets haven't changed, 130/80. The cholesterol targets haven't changed. The only cholesterol that matters is LDL cholesterol, the bad cholesterol. And you want to get people below 2, or at least reduce their LDL by 50%, which means that almost everybody has to go on a statin. Only about 15% of LDL is reduced by dietary interventions. The dietitians in the room can agree or disagree with me, but the bottom line is most people need statins. Almost everybody needs statins. And there are drugs that are protective, cardio-renal protective for the heart, protective for the brain, protective for the kidney. These include blood pressure medications that are ACE inhibitors or ARBs, so that's why we recommend most people with diabetes, especially First Nations people, be on these drugs to protect their kidneys. Oh, and also to lower their blood pressure. We don't use aspirin unless people have had a heart attack. So aspirin is not recommended as a preventive kind of therapy. We have new evidence now around glucose-lowering therapies for the first time that are protective for heart disease. So two classes of drugs that we use to treat diabetes include the SGLT2 inhibitors. These are the ones that work in the kidney, and I'll come back to these. And also the injectable GLP-1 analogs like Victoza or Trulicity or the new one, the once weekly, the Ozempic. These have demonstrated benefit in cardiovascular disease reduction and death rate reduction like the statins. So they're now in the guidelines, and I'll show you where they fit in the guidelines around cardioprotective. Of course, E for exercise and healthy lifestyle, S for smoking cessation, S for screening for complications, and S for self-management and stress. We could have had 4 S's. Okay. So what are the targets? The targets have not changed for the most part. Kind of the presentation of how to think of targets has changed. So 7% for almost everybody with type 1 or type 2 diabetes is still the recommended guideline target. So that hasn't changed. But 6.5% is what you should be targeting in people who are pretty healthy, and you can easily get them down there with 1 or 2 drugs, because we know that if you get patients down to 6.5%, you are already doing benefits to protect against kidney disease and eye disease, the microvascular disease complications. So 7% is fine, but if you can get them down to 6.5, it's better, all right, if you can do it safely. There is this relax target between 7.1 and 8.5% that should not be your target for all people with diabetes. It should only be for special people. And those special people are people who are like frail elderly or dementia, or they're disabled and it's hard for them to do other types of things, manage their diabetes. If they have limited life expectancy, if they have cancer, or they have other terminal type of diseases, or if they've had a history of repeated hypoglycemia, low blood sugars, and they're not even aware that they're going there, and they're very labile in their diabetes. Those are people you can have a more relaxed target. And that more, for the most part, applies more to type 1 diabetes and type 2 diabetes. Okay, so those are the targets for blood sugar. Physical activity, most people think that there's still this awareness that people lose weight by doing exercise. Not really. People lose weight by cutting calories, right? 25 years of nutritional research studies have demonstrated that over and over and over and over and over. I don't care how they lose calories. Whatever fad diet, the problem with fad diet's a 4-letter word, is it implies temporary. You want people to change their lifestyle. So whatever it is they have to do, cutting 500 calories a day, they'll lose 5 to 10 to 15% of their body weight over, depending if they can stick with it. But then adding exercise into the mix to help them keep the weight off, right? The goal is about 150 minutes of moderate to vigorous intensity aerobic exercise per week. That includes walking. Resistance exercise is good, and try to set goals for people. Pedometers are a great thing for people to use, trying to get to 10,000 steps. It's easy to get to 5,000 steps, that's everyday life, but to get to 10,000 you really have to add in an extra 30 to 60 minute walk on a daily basis. Okay. Nutritional management, if you have access to a registered dietitian, that's great. But it's still basic cutting calories. Just sitting down with somebody and say, what do you eat? What can we do to cut out 500 calories a day? What can we do to eat a healthier? What can we do to cut down some of these snacks? Or to not have seconds or what have you? And it's some basic information around understanding how people eat and understanding what's not healthy in their diet. Okay, so in terms of, now I'm going to walk you through the drugs. So I apologize to the non-clinicians in the room. There is the opportunity to get into a lot more depth around this. One of the things that we offer through the program is called our boot camp. You're going to meet Betty Harvey tomorrow, who's a nurse practitioner who works with me in our diabetes clinic here in London. Her and Amanda, one of my other colleagues in the clinic, who's a diabetes nurse educator, run a fantastic program called Diabetes Boot Camp. And it's a deep dive into the guidelines, really hands-on, and it's one of the things that we offer to you as part of this potpourri of programs like the registry, the PDSAs, etc., that you can sign up for if you want, and we'll run a boot camp for you, and it'll be specified for your community at a time that's convenient for you and your clinical colleagues. Metformin is king. Metformin's always the first drug of choice. It's safe. We've had it around for 25 years. We know it really well. And it's going to be atop the food chain for guideline first choice forever, at least until I die. I don't know about, after that, hopefully beyond that. But it's going to be the first drug of choice in guidelines for diabetes for years and years and years to come. The goal is to get people to target within 3 to 6 months. And one of the things that we see is a lot of inertia. Oh, well, yeah, it was my birthday, and then I was away, and I was on vacation, and I'll come back in 6 months. And it's the same, well, next year, I'm going to be my New Year's resolution. And we want to move away and try and get people, no, you've got this disease now. get to target. What are we going to do in the next 3 months, 6 months at the outset? And if one drug doesn't do it, then we're putting you on as many as it takes to get you down to target. This is the algorithm, which hasn't changed that much, but there's a couple of things that I'm going to show you. They used to have, if above 7%, if they're not a target, you put them on lifestyle and metformin, and then it was 7 to 8.5%, and then above 8.5%. What they've done in the new guidelines that they haven't set an A1C target. They just said if you're less than 1.5% above target, i.e. less than 8.5, you would start them on lifestyle and metformin. If they're above that, then you would start probably on 2 oral agents at the same time, metformin and another drug on top of lifestyle. And if they're really symptomatic and they've looked like they've got metabolic decompensation, you would consider starting them on insulin, and they're really extreme. And we see people like that. And then, you would, that's fine. Go to the next slide. What's new in the guidelines is whether or not you have somebody who has cardiovascular disease, heart disease, stroke, TIAs. And if they have that, then now the second line drug of choice is a cardioprotective glucose-lowering agent that has been demonstrated in big trials to have benefits in reducing risk of death from heart disease and stroke. And that includes empagliflozin, which is Jardiance, canagliflozin, which is Invokana. These are the SGLT2 inhibitor drugs that act like a diuretic and are particularly of benefit in people with heart failure. And that also includes the injectable liraglutide, and what will be added to this also semaglutide. These are the GLP-1 analogs, Victoza, Ozempic, which have demonstrated cardiac benefit as well. Not covered under the formulary, but if you have people with private insurance, they are covered, and they're great drugs. They are an injection, but they're not insulin. And now they come in a once-weekly format. So these are really good drugs that are particularly good for people with a history of heart disease. And then, of course, there's this. Now the guidelines do their thing. They get busy and get hard to read and follow. Now you're going to quote unquote individualize therapy with a potpourri of glucose-lowering agents that you have to choose. Is it an easy choice? Well, there are over 60 different glucose-lowering drugs in Canada available now. So go ahead, pick which one you want, which is a problem, particularly in primary care. Like, how do you decide? But you have to look at other considerations. You look at coverage. You look at, do they have kidney disease? Do they have heart disease? Are they going to get pregnant? Are there opportunities to improve adherence? Like combination therapies to reduce the pill burden, etc. All of these are the considerations when you consider all the different drugs. And here they are. It's a simple table. These are by the classes. So there are different classes of drugs, and I'm going to walk you through these fairly quickly. But you can see that what the guidelines have tried to do is say, is there any risk for hypoglycemia? Because if you can avoid hypoglycemia risk, that should always be your preferred second line after metformin. I don't like sulfonylureas because they put patients at risk for hypoglycemia, and they facilitate weight gain. And there are better drugs. There are newer drugs. Formularies like NIHB love sulfonylureas because they're cheap. Right? So, but DPP-4s are equally as good, like Januvia. SGLT2s are equally as good, if not better. And then the injectable GLP-1. So these are all the different drugs. The guideline gives you a table for risk for hypoglycemia, risk for weight, their efficacy, how powerful they are. So insulin is the most powerful lowering glucose agent, but GLP-1 analogs, the injectable ones, are second, and then SGLT2s. And then what are the individual characteristics around the drugs that have been shown in the trials. And now also they have a special section on those that have demonstrated cardiovascular safety and cardiovascular benefit. So I'm not going to walk you through this. Aren't you happy about that? But you can reference it and you'll see it in the guidelines. let's go back to Maria. You put her on metformin, you diagnosed her with diabetes, you gave her lifestyle counseling, put her on metformin. She is trying to cut down on her smoking and maybe lose a bit of weight. But as you can see, her A1C hasn't improved that much. It's 8%. You put her on her statin, so her LDL cholesterol came down nicely to 1.9. She's still got a good kidney function. Her GFR is 90, so that means that she doesn't really have any signs of kidney disease yet. So what's your next step? Do you want to increase the dose of metformin? She's on a gram BID, 1,000 milligrams twice a day. Or do you want to continue on the same dose? Do you want to do nothing and tell her to come back in 6 months or a year? Add another oral agent or add insulin? Who would pick A?
You all have colors on your
we got
table,
colors. Thank you.
for the A, B, C, and D. So take a minute as a group to come up with your answer, and then we'll come back and you can hold up the one you have chosen.
That was my glass of water.
You can have this one right here.
Yeah, no, we used it. Okay. We have A, C, D. We have a C, we have a C. All right, so what would I do? Because I'm not telling either any of you are wrong, but what I would do is I would probably, and the guidelines would suggest that you would choose C, add another agent, because you need to get, she's at 8%, adding a bit more metformin is not going to drop her A1C by 1%. You could consider insulin, especially if she had complications. You know, she had bad kidney disease or heart disease. But the guidelines would recommend this would be a patient you'd add another second oral agent, with ideally one that's going to lower A1C by about 1%, so to get her down to target of 7%.
Should Maria decide what she wants to do?
It's a good question. You tell me.
Yeah, she should, because you can prescribe another oral heart agent. You can prescribe her insulin.
Right.
Ultimately, if she doesn't want to take it,
Sure.
she'll take the prescription,
Right.
refill it, not take it. Then you'll be there, in 3 months when you're checking in, your A1C's still up.
Right.
So really, you should be E. Talk to her, see which one she wants to do, but you definitely want to do something.
So that's individualizing treatment, right? Obviously, engaging the individual in the decision making. That's the optimal. I think it's a good point. Thanks for bringing that out. Yep.
Another thing, we were noticing that she has gained weight. So, if she can get back to the dietitian, combination of this, right? Because ultimately she has to self-manage.
Yep, and you have to help her.
Yep.
If she's wanting the help, right? Which is what you want to have the conversation about. Okay, good discussion. Okay, so what if her A1C was, we'll give you another clinical scenario. What if it wasn't 8%, it was 8.7%, it was going in the wrong direction completely? What would you want to do now? So you know how to use your cards now. Choose increasing dose of metformin, switch to same choices. Let's assume E as part of your conversation here, all right? So which one would you choose? You guys can have a quick conversation at your table. You have the same patient, but her A1C is actually worse. It's 8.7%. What would you do now?
I would say
Okay. You ready to commit? All right, put up your cards. I have a D. I have 2 Ds. You want to show your cards? What are you going to do as a table?
we're going to do A and D.
A and D, okay. D. Okay, insulin. Oh, good. Or both A and C. A, considered adding another oil agent. Okay, so metformin, I can tell you that when patients get up to about 1,500 milligrams of dose, that's like 80% of the efficacy. So to go up to 2,000, which is fine, because that's how the tablets tend to come, but go beyond 2,000, you're not going to get anything more other than diarrhea. So 2 grams is kind of your max, and and you're not going to get much more big bang for the buck. Adding another oral agent, or even 2, or even considering insulin would be all good options. Okay. So, here's diabetes. Now the good and bad about diabetes, type 2 diabetes, which is what we're focusing our discussion on because that's what Indigenous Canadians primarily have. If they have type 1 diabetes, by the way, there's likely admixture, intermarriage from non-native people that has brought kind of the risk for type 1 diabetes. First Nations people don't get type 1 diabetes. They only get type 2. So if there is type 1, but it generally means that there's been some intermarriage, from outside Indigenous groups.
Pancreatitis sometimes too?
Yeah, if you've had a traumatic injury to the pancreas or you've had severe pancreatitis, which basically kind of turns you into a type 1 because you're not making much beta cells, but sure, absolutely, yeah. So diabetes, type 2 diabetes is a complicated disease. It's a multi-organ disease. There's at least 8 different pathways that contribute to high blood sugars. And so that's why it's hard to treat. But the good thing is that pharmaceutical companies have been clever because they've developed drugs that target specific components of the underlying pathophysiology of type 2 diabetes. So for example, you can have drugs that target and delay absorption of food. It's called glucobay, which we don't use much in Canada because it's not a very effective drug. It's still available. It's not covered on most formulas. It doesn't lower A1C all that much, and it causes a lot of gas. So it's not a drug you want to be on maximum dose if you have open fires. Okay, so we just don't use it very much. Metformin primarily works in the liver to tell the liver not to make sugar because there's lots of sugar around in the bloodstream. That's where metformin works. We used to use TZDs. This was Avandia and Actos. We don't use them very much, but they target insulin resistance, so they make the body's insulin work more effectively. We have drugs that tell the pancreas to make more insulin. So that's how secretagogues work, SUs, such as diamycin or glucoside and glyburide, or DPP-4 inhibitors like Januvia, Onglyza, Tradjenta. These are drugs that facilitate the pancreas to make more insulin. The advantage of DPP-4s over SUs is they don't cause hypoglycemia. When the sugars come to normal, their mechanism shuts off. The problem with SUs, sulfonylureas, is that they continue to tell the pancreas to overproduce insulin and put the patient at risk for hypoglycemia. DPP-4s are weight neutral. SUs cause weight gain. So you can see why my preference is DPP-4s because they're safer, better tolerated, they don't cause weight gain, and don't put the patient at risk for hypoglycemia and work equally as well as an SU. You can get a super benefit if you do the injectable incretins. So DPP-4s and GLP-1s are called incretins. These are a hormone that tell the pancreas to make insulin in response to food, and they give you a super physiologic dose, which really gives you a bigger bang for the buck, if you would, and they cause weight loss. So we now have 2 classes of drugs. When we put patients on them, they not only effectively help lower blood sugars, but we see weight loss associated, which is something we're trying to promote in all of our patients with type 2 diabetes. And then finally, the new kids on the block are the ones that work in the kidney, and these are the SGLT2 inhibitors, and I'm going to walk you through all of these. And these prevent the kidney from absorbing glucose that's spilled out from the blood into the urine, and therefore you pee out sugar. You pee out about 400 calories of sugar. It's a peeing diet. So people lose weight. They lose weight on average about 3 kilograms just by peeing out sugar, and that's how these drugs work, and they're very effective at lowering blood sugars as well. So next slide. I've kind of walked you through these quickly, so I'm going to flash through these and save some time this way. how they work. That's metformin, sulfonylureas, as I've discussed, and why I don't like them, weight gain and hypoglycemia, and they don't work so well after in people. These are where the SGLT2s work, very complex, but basically they prevent the kidney from reabsorbing glucose, and so you pee out your sugar, and that's how you lower your blood sugars in general, and you get weight loss because of that 400 calorie sugar loss through the urine. Did you have a question? No. Okay. These are the incretins, as I mentioned. The nice thing about all of these diabetes drugs is they all play nice in the sandbox. Because they all target different components of the underlying pathophysiology, you can combine them. And that's why we often have patients on 2 to 4 different glucose-lowering therapies, and including insulin. So these are the drug names. I can tell you that NIHB, which most people are going to have as their formulary coverage in your communities, the GLP-1 agonists, the injectables, are not covered, unfortunately, but the DPP-4s and SGLT2 inhibitors and the combinations that come where the DPP-4s are combined with metformin are all covered by NIHB under limited use.
Actually, Victoza is an exception if you write enough letters.
If you write enough letters. Okay, well, in Ozempic, hopefully will be there as well. That's the once weekly. That is the most powerful glucose-lowering agent we have next to insulin. That's just new on the market. But amazing weight loss, up to 10% of body weight. People are losing like 10 kilograms on these drugs. And most effective lowering A1C, 2% reduction in A1C. So you'll hear more about it, and have now demonstrated cardiovascular benefit in reducing death rates. So the drugs keep getting better and better and better with good safety profiles, additional benefits actually. The problem is that formularies like to stick with what's old and cheap. And NIHB is no exception. But these are on there, and I would really recommend that you use combination therapies, consider use of SGLT2 inhibitors where you can, because of the added benefits, etc. Yep.
Any word on Invokana and the increased risk of amputation?
Yeah, so there are 3 SGLT2 inhibitors on the market. There's Jardiance, which has demonstrated cardiovascular benefits. There's Invokana, which has cardiovascular benefits demonstrated. And there's Forxiga, and its cardiovascular outcome trial is going to be presented later this year. So we'll see if it also has the same benefits. One would expect it's probably a class effect. In the big cardiovascular outcome trial for Invokana, they noticed that there was a small but statistically significant group of people that had increased rates of amputation, small digit, toes kind of thing. And it was a surprise, but it had to do in part with how they designed the trial and how they were looking for those kind of complications, not seen in the other SGLT2 inhibitors, but it's in the label, and it's a warning that if you have patients who have a history of amputation, you should not use these drugs. That's how I would approach it. That's what
they're still not sure why.
Nobody knows why, which is why it's perplexing that it was found, but they had more people who had history of amputations in the trial. There's lots of, lots of noise around what it might be, and when we have the big Forxiga trial called DECLARE coming out, 18,000 patients in that trial, huge study, and everybody's going to be looking to see if there's any increased signal around amputations. Okay, insulins, insulins rock. These are good drugs. And often, as I said, for people who have long-standing diabetes, they need insulin. And the nice thing about insulins is that there's been new evolution of insulin therapy to more closely mimic normal human physiology in people who don't have diabetes. Bottom line is the newer insulins are safer. They're safer in terms of reduced risk for hypoglycemia. So there are now new basal insulins, not on the formulary yet. So a new and improved Lantus called Toujeo, which reduces your risk for overnight lows, nocturnal hypoglycemias by about 25%. So a new and improved Lantus if you want. It's like this year's model of Lantus. And then there's a new long-acting insulin which it hangs around forever and is very steady called Tresiba. not also on the formulary, but also reduces your risk for lows like Toujeo does. What the formulary, what NIHB makes you do is put people on intermediate basal insulin, NPH. To me, it's unethical because what you're supposed to do is induce hypoglycemia in your patients, and then you can use a safer, I mean, that's crazy. It's like, we'll give you a safer car only after you're in an accident because the brakes don't work as well in the old model. But the new model, they're better. So that's what they're making you do in patients. So, you know, you got any patient who you can kind of tease out, maybe they had a hypo, boom, then you can get coverage for the safer basal insulins, and that's what I would do. Because it's a drug that was discovered in 1948, and there's new and improved versions, all right, for heaven's sakes. And then pre-mixed insulins, I'm not a big fan of pre-mixed insulins. I think they're hard to titrate, puts patients at risk for hypoglycemia. If they need a pre-meal insulin, use a pre-meal insulin. And the newer ones, you know, Novorapid and Napidra and Humalog, all are safer. They work quicker, they get off quicker, so the risk for lows is reduced. Safety, safety, safety. These are how the different insulins work. I think I'm going to save this for boot camp if you guys want to do boot camp, because they go into great detail about this, so you get very comfortable learning and understanding how to use insulins. And I've kind of covered what's covered under NIHB, so we can skip this as well. Let's go back to Maria. So she's upset when you tell her, yeah, you had the conversation, you should go on another drug. And she says, I don't want to go on another drug. And actually, I don't like taking pills. That's why I haven't actually been taking my medication so much. That's why her A1C went up, not down. And whatever you do, don't mention the word insulin or needles, because, you know, if she remembers when her dad died, right before he died, they put him on insulin. Maybe that's what caused his death. You know, people have these preconceived ideas. And that's why when I have a newly diagnosed patient with diabetes, I introduce the concept of insulin at diagnosis, so that it's not an end of stage treatment. And so people don't have that fear like I must be bad, or I've been bad, or I have bad diabetes. It's just that it's one of the therapies we use, and you explain why insulin is important, how it works, and how over time you make less insulin. So when you have that conversation, well, it's time that we need insulin because you're not making enough, people will have a little bit different perception, hopefully. And it won't be as Maria says, I don't want needles. So here, back to your tables. Her A1C is 8.7%, so again, going north, not south. Her LDL is still good, kidneys are still good. She's on max dose of metformin, when she takes it, but she's probably not taking it very often. What's your best second line agent now that ABCD, so have a little combo at your table. Choose one. What time is it?
How many slides you have, but maybe after this one, try to get it done in 2-3 minutes. I think you're almost done.
I got complications, but I'll fly through.
Okay.
I'm skipping through stuff.
Okay.
Yeah. All right, flash up your cards. What do you want to do for her? A, B, C, or D? DPP-4 inhibitors, GLP-1 analogs, sulfonylureas, or insulin? A D, insulin. All right. What is that? E? E. All right. Oh, he's never going to give up on that. But that's the key issue, right? Is non-adherence. So, right. You got to get through that first before you can even think about another drug.
Yeah, but you might be able to get away with a combo therapy.
Absolutely.
Because that's still one pill.
Yep.
But you can add another agent.
My favorite conversation with patients is, what if I put you, instead of, I cut down from 5 to 2, the number of pills you're taking, which is what you can do. If they're on a DPP-4 inhibitor, let's say, and 4 metformin a day, you can put them on a combo tablet that can be once a day if you use the extended release, which is covered. or one twice a day. And people go, what? You're going to cut down the number of pills? Yeah, but I'm going to sneakily kind of improve your adherence. So, little tricks that you can play, but you have the conversation with the patient.
You wouldn't.
I wouldn't.
You wouldn't.
Would not be. No, I would never do that.
No, it's not a trick, but what you're doing is you're agreeing with them. Like, you know what, I don't want you to have more pills either.
Right.
So there is a way we can accomplish both. You want to have one less pill.
Right.
And we can add, and I want to help your A1C down.
Yeah.
So we can add a med and you still have
And it switches the nature of the conversation, saying, you should be taking your pills. Now it's like, can we do anything to help you remember to take your pills more effectively? So one pill twice a day.
So
Yeah.
what was the correct answer to the last one?
I like the combination option or insulin. 8.7%, she's not in good control. And now time is wearing on. Now you're worrying about complications evolving. Okay. So again, we had the combination of fixed dose. Some people who are on lots, if they've got other chronic diseases, they're on lots of pills. So blister packing, if that's available to you, is a really good strategy to help people to remember the pills, etc. Simplify therapy always. Okay. Let's get into gestational. I touched on this earlier. Next slide. And we know that gestational diabetes is 3 times higher in First Nations women. This is a study that we did here in Ontario. And because diabetes is developing in pregnancy, it's not just the woman who's now developing diabetes during the pregnancy, because pregnancy is a diabetes-inducing state. It increases insulin resistance because of the pregnancy hormones, so it kind of unmasks someone who's probably pre-diabetic, if you would. But it also, you now have identified somebody who's at very high risk for developing diabetes. It's like a screening test for diabetes, if you would, in a high-risk state called pregnancy. But it's not just the woman that's at risk now, it's that baby that's at risk for developing diabetes. And we know that things like macrosomia, big babies, and the environment, there's new research coming out that shows that the environment, if sugars are high and they have diabetes and it's not controlled, the risk for that growing child to develop diabetes is much higher at a much younger age, and the risk for complications is much higher at a much younger age. So it's an opportunity for intervention, because if women are going to be interested and focused on trying to be healthy, etc., your best shot is during pregnancy, when that they're really, really keen to try and be as healthy as possible to protect their growing baby. So the recommendations from the guidelines basically haven't changed. I wish they would have simplified. I argued for 15 years to simplify this, but I can see they haven't. They still offer 2 options, a 50-gram glucose challenge. If they haven't had a history of diabetes, you do it in the 2nd trimester between 24 and 28 weeks. You give them a 50-gram load. If that's elevated, you give them, then they do a 75-gram glucose challenge test. The simpler is to just offer a 75-gram oral glucose tolerance test, which is what other guidelines recommend, and I think the evidence is pretty good. So they only have to have it done once rather than twice. And those are the criteria for diagnosis of gestational diabetes. If they have elevations of any of those, fasting greater than 5, 1 hour greater than 10, or 2 hour greater than 8.5. They have diagnosis of diabetes, of gestational diabetes. Gestational diabetes means diabetes diagnosed during gestation, during pregnancy. Okay. This is a great opportunity to bring the dietitian back in if you have access to one, or to at least revisit the whole issue around lifestyle, achieving good, tight controls. The most stringent diabetes targets are in the guidelines are during pregnancy. They're almost sometimes below the target blood sugars, because of the evidence showing that high blood sugars are bad for the developing fetus. So you can see that your numbers are very aggressive in terms of 1 hour, 2 hour blood sugars. And the only drug that's safe to use in pregnancy is insulin. They should be off metformin. They should not be on a secretagogue. They shouldn't be on any other drugs. So that's why a lot of women go on insulin when they have gestational diabetes, because that's the safest drug to use for both the mom and the baby during the pregnancy. Okay. If they're on anything else going into the pregnancy, they should be off their ACE inhibitors. They should be off their statins. They should, you really have to use drugs or take people off drugs during the time frame of the pregnancy. Next. Okay, I'm going to finish off talking about complications of diabetes. I'm going to fly through this. I've already talked to you about the microvascular disease complications, small blood vessels, kidney, eye, and nerves. And then the big vessel disease, heart disease, brain disease, and peripheral artery disease. Next. Focus on end-stage renal disease. I already kind of bigged this up at the beginning of my presentation. This is a huge problem. And if patients have to go on dialysis, the disruption that has to that individual if they have to leave the community and their family, and they have to move to a center where there's dialysis accessible. So you want to pull out all the stops to prevent that from happening, because it is such a life-changing complication, not just for the individual, and it ain't fun to be on dialysis 3 times a week, but also the family that has to get dragged out to a larger center if they have to go on dialysis, etc. And the implications it has on family and people having to leave reserve, etc. So be very aggressive at screening for kidney disease. You want to do your ACR, your urine test, for looking for protein and microalbuminuria in the protein. You want to and the diagnosis of chronic kidney disease is either if they've got some spillage of protein and microalbumin in the urine, or their GFR, their kidney test, is less than 60, and then you're going to be all over them. Blood sugar control, blood pressure control, statin control to protect their kidneys. Forget the diabetes, protect their kidneys. Don't forget the diabetes, but you're treating the diabetes to protect their kidneys. I can't stress it enough, because it is such a problem in First Nations, people with diabetes. This is just kind of the progression of what happens in protein in the urine. I think we'll skip through that. Again, this is highlighted more in the boot camp. And then heart disease. So if you look back in history in Canada, and you look at the causes of death in First Nations people, prior to the 1990s, heart disease was way down there as a cause of death. First Nations people did not get heart disease. They died of other things, trauma, starvation, infectious diseases, etc., but they didn't die of heart disease. Now it's the leading cause of death, and it's all diabetes. It's all diabetes. So it's completely changed what First Nations people are dying from. So we're very aggressive at trying to target cardiovascular risk factors. So that's blood pressure, that's cholesterol, that's weight, it's diabetes. And so you should be very aggressive at preventing heart disease in your patients, because that's what they're going to die from. People die from other things with diabetes. Cancer rates are all increased if you have diabetes. And the worse you control, the increased risk for cancers, but in particular cardiovascular disease. Next slide. So back to the ABCDESs, same kind of thing that I went through at the beginning of the presentation, especially smoking cessation, and the high smoking rates in Canada are on reserve. Ironic that in many reserves, that's like the leading source of income, is to sell cigarettes, but hopefully to people outside the reserve. But in fact, smoking rates are very high in kids. So smoking cessation programs might be something you want to focus in PDSAs in your communities, just knowing how high it is and how it increases risk for cardiovascular disease. Blood pressure targets haven't changed, so nothing new under the sun here in the guidelines, 130/80, and remember that most people, it's kind of a progressive chronic disease, hypertension, so you need to generally add more and more blood pressure medications over time. And then cholesterol, as I mentioned earlier on. And the only time we consider a fibrate as a cholesterol-lowering agent is if their triglycerides are above 10, because it puts them at risk for pancreatitis. And so you want to get it down. And remember, you can't measure LDL if your triglycerides are above 4.5 or 5 anyhow. Otherwise, we don't use them much. They haven't demonstrated cardiovascular benefits. And statins are your main drugs. Okay. Let's look at Maria. She's now 50 years old. She looks stressed to you. She's missed several checkup appointments. She again admits to this non-adherence issue. Her A1C is 8%, so she's taking some drugs, but now she's got established, she's spilling some protein microalbuminuria in her urine. You've mentioned her ACR. She's not been taking her statin, obviously. Remember, she was at target, but she's now 3.2. She's 50. You're really starting to worry about her risk for having a heart attack or stroke. And then, so you really want to make sure that she's taking either an ACE inhibitor or an ARB or a combination tablet. Again, whenever you can use combination tablets, use them. Where you're going to use a diuretic in an ACE inhibitor, or the preferred second line after an ACE inhibitor is a calcium channel blocker like amlodipine. And then a diuretic would be number 3. I'm going to skip through for the sake of time. And then also, I've kind of covered off the need for her to go back on her statin, or potentially a statin plus ezetrol, ezetimibe, to get her down to target if the statin won't do it alone. Last word is on amputations. So again, First Nations people, much higher risk for amputations, so you should really be focusing on feet. And I have to tell you that many of the Forge Ahead communities, this was a major focus of some of their PDSAs to try and do better foot examination, foot screening. One community noticed that the men never came in for their appointments. They looked at all their diabetics that came into or the people with diabetes that came through the clinic. It was mostly women and not the men. And they said, well, we don't have any men with diabetes in this community. Not true, obviously. And what they did, they were very clever, is they created a foot screening program, a foot care program, as a hook to get the men to come in. You know, a nail care program. We'll take care of your nails. We'll examine your feet, but we're going to take care of your diabetes while we're painting your toenails, so to speak. I'm exaggerating. But you want to get people to get into the habit of getting people to take their shoes and socks off. And you know, it's tough in winter. Some people don't take their socks off for 3 months. Just sometimes why you don't want them to take their socks off when they come into your clinic. But you want to look at their feet, because these are high risk. And if you can pick up people with neuropathy and teach them proper foot care, you'll prevent amputations. It's simple. If you want to prevent people from losing limbs, teach them how to take care of their feet. Best primary prevention around. So here's, you know, do the monofilament test, you know, check and see what the color of their feet looks like, if there's any breaks in skin, and how to do proper foot care. Next. And then again, this will be covered in a lot more detail. People with diabetes and have neuropathy, their feet change. They get kind of this claw-like foot, and what happens, they get a collapse in the arch of their foot that shoves the metatarsals forward. So you have fat pads where you're supposed to put when you walk. If you push the toes forward, they're not walking on the fat pads anymore. They're just walking on skin. They drive the bone through their skin. They don't even know it. And they have ulcers and amputations. So there's a deformity that happens in people with neuropathy and diabetes that puts them at risk for ulcers and ultimately amputations. And NIHB is good. They'll cover orthotics. So, you know, people need to have...
You can get all the orthotics you want, but if they have poor footwear, what good are they?
Right.
And we've been dealing with this. You know, we have one lady, she definitely needs new sneakers.
Yeah.
And she's okay for orthotics in those garbage sneakers,
right,
but not good footwear. So
yeah,
it's just
it's a battle.
It is a battle.
It's a battle. Okay, in retinopathy, people with diabetes get eye disease, so just routine screening. Many communities have the kind of the retinopathy screening cameras, or visiting optometrists. It's all it takes. It's just, you know, we're not good. Unless you dilate a pupil, it's really hard to pick up retinopathy. So get people who dilate pupils to do it, which is optometrists. They don't have to see ophthalmologists unless they have established retinopathy. Just remember to screen. Next. So Indigenous people are among the highest risk populations. Certainly I'd say the highest in Canada for diabetes and diabetes-related complications. Prevention starts at all stages, including children. Management targets are no different. The guidelines are the same for Indigenous peoples as they are for the general population, with a particular focus on what they're particularly at risk for, kidney disease, and etc. There is the now the acknowledgement of the legacy of colonization that's put us into this mess, so to speak, and the need to kind of work within your communities and access, etc., and recognizing people may not have much money to buy healthy foods, or what are the options that they can buy to have a healthier lifestyle. It's a silent progressive disease. I always have said, you know, if diabetes was like appendicitis, we'd have 100% adherence and treatment and effectiveness, but it's silent. People can't feel their high sugars, and they adapt to feeling when their sugars are high. But you want to individualize therapy. We had a good discussion around that. Don't be scared of insulin. Don't use it as a last resort, as a last rites therapy, as I like to call it. Introduce it into the conversation around trying to keep you healthy so you can live a normal life, which may include at some stage a discussion around the use of insulin. And then don't forget your multifaceted vascular protection strategy. These are the guidelines. That's the website where you can get the guidelines and the summaries of the guidelines and slides of the guidelines and handouts for the guidelines and pamphlets for the guidelines, and 5,000 pages spelling out the details of the guidelines and the evidence. It's not 5,000, but it's long. They have a kind of a lay version for people with diabetes to access now. But I would really, I'm self-promoting the opportunity for boot camp because it's a great program. And it's been very well received by all the communities that have had it. I think I'm done. You get a break. Harsh.